board, you are very welcome, and I welcome our board members and non-executive directors and the members of the public who have given up their precious time to join us today. This is a meeting in public, not a public meeting, but we will come at the end of the agenda to questions from the public. So if people have questions for the executive, then towards the end of the agenda, I will be inviting people to raise their hands and share their questions. So let me first of all just clarify. Apologies. I think we have apologies from Nick Ross, from Andy Bush, and from Beverly.
And Ben just had to leave early.
And Ben will be leaving us in about an hour. So that's thank you very much. Moving on to declarations of interest. Everybody's declarations of interest are posted on the website. Does anyone have any that either they want to add to that or that are specific to the agenda we're dealing with today? Haven't been notified of any in advance. So thank you very much. So moving on to minutes of the previous meeting on the 16th of March. First of all, does anybody have any queries or questions about accuracy? Have you been notified of any?
No, nothing ahead of the meeting.
So are people happy that they are a true and accurate record of the meeting? Thank you very much. We will accept those as a true and accurate record. And then the record of items that from the part 2 of the meeting, those are for noting. Thank you very much. And then we will move on to the action log, of which we have just 2. One of which is around the integrated quality performance report, which we will pick up on the main item of the agenda, and the second was that Professor Ertz would provide a copy of his palliative and end of life survey when it's published, which I think is.
So just just to update on that, so Professor Ertz and I have discussed, so we have got the results of it. We'll take it through executive governance and then bring it back to the next public board meeting.
Perfect. Thank you very much. That is excellent. So moving swiftly on, there is a copy of my written chair's report has been posted. I just take a couple of moments to add to it things that have happened since then and really over the last couple of months. So the last couple of months I have been, since I started on the 1st of April, I've spent a lot of time talking to people, getting to know the organisations, meeting with staff, meeting with the NEDs, meeting with leaders and chief executives of local authorities, who I'm gradually working my way through meeting them all, and then considerable time with the ICS, the region, and the national teams. We clearly have a series of recognised, understood challenges that we face, which I've been talking about a lot with the executive team and with the NEDs, and many of which we'll be talking about on this agenda today. But the challenge to reduce waiting lists and waiting times for surgery, the need to speed emergency access, the need to recover the quality of our patient experience back to where we were pre-COVID, and to support our staff as they come out of COVID and back into normal working, and all of that, I think, are significant challenges alongside the financial plan that we need to put in place to get ourselves back on an even keel going forward. I've been working with the NEDs and the vice chairs and the chief executives across the collaborative to develop our joint working in order to meet those challenges, with the kind of specific aims of ensuring that we are able to deliver the best of what's in North West London to everybody in North West London, address issues of inequality of access by geography and by population, and to try and create the best place to work in the NHS. And we all know that there's a huge amount of work to do there. But I think I just close by thanking the people that have supported me in my first couple of months in this month, both within this trust and the other trusts and the ICS and across the local authorities, who have I think are as one in our ambitions. So I will leave it there and say, has anyone got any questions for me on my report? Okay, thank you very much. In which case, I would like to move on to the first staff story that we have brought to the board. We have, for a number of months now, brought patient stories to the board, and we thought that reflecting the enormous and fantastic work that our staff do and the challenges that they face, it would be good to create a forum where we could share those as well. So, Kevin, you're going to introduce this for us and explain how it's going to work.
Yeah, thank you, Matthew. As you said, we've been having the patient stories, and what we're going to do now is be alternating a patient story with the staff story. We've been piloting this at the People Committee as well, and particularly we've honed in really on stories that are relevant to our strategic people objectives, and actually even honed in further at the People Committee around equality, diversity and inclusion. And we've been hearing from staff who have different protected characteristics. And also we've then been hearing from the chair of the staff network for that particular staff group, so that we've managed to get an individual insight, but also then how does that fit with what's coming through the network. So I'm pleased to introduce Raki Najar, who's one of our senior occupational therapists in major trauma and neuro outliers team. And interestingly, it's almost bridges a staff story and a patient story. It's a really tricky area that in essence has been around since the NHS begun, but has often been hidden or not talked about. And so we've not started with an easy area here, but it sort of is that interface between patient behaviours and the impact on staff. But without further ado, I'll hand over to Raki, who can give her story, and then we can open it up for any observations and questions. So Raki, over to you.
Thank you very much. I'm just popping my camera on and it may just take a moment. Thank you for having me and thank you for the introduction, Kevin. I'm very happy to be here to share my experiences within the trust. And like Kevin said, I am currently a neurology occupational therapist. I've been in the trust for around 4 years, but an OT for over 13 years. So worked in various trusts out of London as well. I'm here to really share my experiences of equality, diversity and inclusion in the workplace. And that does actually include obviously the patient interactions, but also interestingly, the staff interactions and how staff are and the culture in our workplace as well. Early on, I've been very passionate around equality, diversity and inclusion. So the EDI, very early from my career, so in various trusts that I've worked in. And I was very pleased when I joined this trust that you have a huge network. So I became very quickly part of the Allied Health Professionals Race Equity Group, which is very specific to the therapies side of things. And then there's also the trust-wide group as well for BAME as well that I'm part of. And you've got obviously a specific EDI department. So that was really great. And it was a safe space to share ideas and how we can implement change. The great thing is it's from any banding as well. So people from right at the bottom who work at the bottom to sort of our leadership team. So that was really great. And there's two parts really to the experiences that I want to share. It's around the interactions that staff have with other staff that I've witnessed, and also the patient and visitor related as well. In the past year, I've witnessed 2 incidences, related to staff racial abuse. One that I saw in front of myself, and I felt that I was in a position to sort of kindly sort of challenge and say that that's not appropriate, and check in with the staff member afterwards. And the second was a staff member who'd confided in me, and that their manager had actually given them a bit of racial abuse as well. So I sort of tackled that a bit differently, because that was quite sensitive, and we went down an anonymous reporting using the DATEX system that we use in the hospital to report that incident, which then got internally investigated. In terms of the patient related, many colleagues have experienced that. I've done a lot of discussions with my colleagues recently about their experiences, and including students who come to our teams as well have experienced it. So, and that's really difficult because they're very junior, they've not really experienced much around the healthcare service or the NHS. So we want to make a really positive experience for them, and then they come and sometimes experience that. At least in therapies, 1 to 2 times a month, we're at least seeing some reports and DATEX coming through of patient-related abuse towards staff that are racially sort of down that route, and that's quite interesting. Many staff don't have the courage as well to take action. So this is why it made me really sad and disheartened at times, because we're all working really, really hard, and sometimes staff don't want to come to work because, you know, they're feeling like the workplace or the experiences that they're having, the interactions that they're having, are affecting how they're feeling. So that made me really think, what can I do as an individual here to make this, you know, a better experience for everybody? And I felt like I really need to role model good practice, trying to combat things head on if I felt that was appropriate, or reporting them. But I really wanted to empower our staff to do a DATEX, or even speak to their leadership team and their managers. It's not okay to be abused in any sense, and it's not part of our jobs. And I think that's what a lot of people feel is, you know, we need to tolerate this and we still need to provide care. But actually, it's very important to say, well, you know, there is a boundary here, and we need to set that boundary to protect our well-being and to protect our own mental health as well. So this is where I came from most recently, and I've developed a training on creating a culture of inclusion, which I did with my team recently. It was a really lovely workshop, and I took a lot of data from the trust about the mix of our staffing, about our staff surveys as well, and what the staff are saying in terms of their experiences around EDI and, you know, abuse from each other. So I took a lot of data from that, and we also did a practical element where I got the staff to look at making pledges on how they could make a difference within our workplace on creating that inclusion. So that was really a lovely session. And in terms of following up, I'd like to do a reflective session around that and review the pledges and see if any of these things have been put into action. And if not, what are the barriers? Why aren't these things happening? You know, so that we can think about it and think about how we can make change. I also want to do some bite-sized trainings with the team around sort of unconscious biases and microaggressions and things like that, so that we can take this a bit further, because a lot of it's around educating each other and empowering each other as well. I think overall, my vision would be to sort of really roll out similar trainings across sort of therapies and you know, anywhere that would be interested really, to kind of educate the staff and empower the staff. And that would be sort of something that I'd be really keen to do and be involved in. And I think well, no matter what band you are, you can always make a difference. And I think that's really what I want to sort of empower others to do. It's not about your position sometimes, because your position is powerful wherever you are. So I think that that's a really nice way to kind of interact with the other staff. In terms of the support that I've had from the trust, so I went on the active bystander training quite a long time ago, which I found a positive experience. and there's lots of around allyship in leadership, and also leadership training for equality, diversity and inclusion, which the therapies leadership team has undertaken as well. And there's lots of things locally around the meetings that we have, and having that protected time to actually be able to talk to each other, because a lot of the things that a lot of us are doing around sort of racial equity and making changes, we're doing in our own time. You know, a lot of us are clinical, and because we're so passionate, we really want to make a change. In terms of the other thing that the trust is supporting me with is that I am on a leadership master's apprenticeship program, which has been an incredible experience, and I'm very grateful to that, because if I do feel if it wasn't for that, I wouldn't have the confidence to lead change and want to transform and take it further than my little area, but take it to therapies and to bring it to yourselves. So thank you for that as well. It's been an incredible experience. In terms of future changes and things that I can't always control because it's way above my area, is really around recruitment and the fairness in recruitment, and looking at the diversity in senior leadership posts and that kind of thing would be incredible, you know, to see that there's changes happening to empower our staff, and more reaching out from a senior leadership point of view to sort of the frontline level staff, because we know, and I know in the position that I am, that there's lots happening within this trust. It's just sometimes not everybody knows sort of at the level or below me of what's actually happening. So that would be quite nice. And more feedback around the Datex reports that are happening, because I know that there's a lot of them out there, but having more feedback and actions on where things are going would be amazing as well. Thank you very much.
Thank you, Raki. That's really, really amazing. And you're really championing this work in your area. And Matthew, when me and Sim talked about the staff stories, we really wanted to bring challenging areas, not sort of success stories. So whilst it's a success in Raki's area, we've got so much to do on this issue, as you'll see from the staff survey results in the rest of the trust. So whilst that might have sounded positive and Raki's done some great work, we've got loads to do, and that's partly what we wanted to share with the staff stories, rather than sort of bringing success, reflect the challenges that we've got, really. So I'll just open it up for any comments or questions.
Yeah, well, thank you very much, Raki, and that, I mean, thank you so much for what you're doing, and that's a great story. We've got lots of people who want to ask questions, but I'd just like to throw you one first. There is there's the whole training and cultural change piece that you're talking about. Do you think that staff who face racial abuse out there know that we are dealing with it and know that the senior management have got their backs? And is there anything that we could be doing to make it kind of part of people are just confident that we're on their side?
So like I said, I think this is where things get filtered down. So certainly in therapies, one of our main meetings, for example, we did sort of the leadership team did tackle that, and then we sort of filtered that through. But it's just really, that's what's happening in therapies. But I think trust-wide, it doesn't always get to everywhere. So in terms of, say, nursing or medics and things like that, I don't know how it's sort of working. And that's, I think, ultimately my vision eventually, is that everyone gets to that point. And I think there is a lot of work to be done there. And I think it really does come from your immediate line managers having a buy-in. And like I said, with the therapies team, the leadership team, they have been incredibly supportive, and they have been wanting to change and taking on those trainings. So I think encouraging sort of the senior leaders to sort of do that, and the people below them, etc., because it's kind of like a bit of a waterfall effect, I think.
Great, thank you very much. Let's take questions and comments. Bob.
Thanks, Matthew. Thank you so much, Raki, for sharing this with us. And Kevin, I think you're absolutely right. It's lovely to see the staff stories making their way to the full board now. So thank you for bringing this one. And your point about making them real, where there's real action that we can learn from, is absolutely well made. And that's where I want to go some of the recommendations and next steps coming there. Some of them are quite hard edged. I'd expect to see some measurable output coming from next steps of reviewing things, which then imply an implementation of something. And I'm not sure what your plan for doing that is, but I would urge the People Committee to be very, very active in this space. And I look forward to seeing People Committee updates to the full board reflecting back on measurable delivery of some of the next steps that have come out of this absolutely excellent staff story. Thank you very much indeed.
Thanks, Bob. Kay?
Yeah, I'd just like to echo my thanks as well. An incredibly balanced account of your experience, particularly given the racism you've experienced in that, and also for your leadership. But I suppose in some ways I'm sat here feeling uncomfortable about the disproportionate burden that's still on people of colour to champion change. And you have taken that challenge. But I just wondered, you talk, as Bob has said, about a lot of key learning and action, but it's still very much at a trust level. What would your asks be of me as a white woman or individual colleagues to try and take some of the burden off you? Because, this is all of our problem.
Oh, Raki.
Thank you. So I think that's where obviously we have lots of initiatives across London, one of them being the RES, and there's a huge part around the allyship. So that's exactly where somebody like yourselves in a position that's sort of in a leadership position who can sort of really engage with these groups, like our chief AHP leader, Chris, is very much involved with our meetings. So he does come to our meetings, and he likes to be involved with what's happening. So we've got a great ally in therapies, and it's just about having sometimes, more than welcome to, invite somebody like yourself who was interested to come to one of these meetings. And I'm sure that they're going on sort of across the trust in the different divisions as well. And, just really kind of hear some of our stories and experiences, because when I did the workshop with my colleagues, obviously we're all of mixed background and from an EDI background. And I think it was really nice for people to kind of really understand what we were facing. And, the pledges that some of them had written were really lovely around supporting each other, about standing up for, what isn't appropriate. So, yes, on a day-to-day basis, little things can be done, but certainly from a leadership team, you can be as involved as you want to be.
Great, thank you. Let me take a couple more comments. Simp.
Thank you, Matthew. Thank you, Reiki. You've added to the momentum of this agenda. This is an amazing conversation to be having at board level. So I thank you for your contribution, and we hear what you're saying. So just to comment on something Bob said, yes, the People Committee have this in its sights and have had this issue and this agenda item on its site, and we continue to look for metrics and impact to create a real difference. And it's by having conversations with people like you where we can measure to some extent on an ad hoc level whether anything we're doing has the impact. So there's still work to do, we can hear that. But from your point of view, Reiki, can you help us? You're extremely engaged. What can we do to encourage others that perhaps aren't so engaged to answer our pulse surveys and just engage with the trust to make sure that we're listening to them as well? Because what we're finding is a sort of a mixed reaction in terms of wanting to feed back to us. So the more information we have, the more activity and action can be focused, targeted, and can be put in place to make things better and improve staff experience, especially for those staff of ethnic minorities. So what else can we do to get people more engaged?
I think that's you know, definitely coming from the leadership teams. And I think part of it is, you know, we can't just put all the pressure on that as well. I think we as clinicians and senior leaders and just general employees also need to take a bit of responsibility for that. So that's certainly something that I'm trying to do locally around sort of empowering the staff that I interact with and work with to discuss these things, to be involved in our race equity, to go on the active bystander training, or, you know, what other things that they need to do to feel empowered. And especially around the staff survey as well, that's a huge area that, you know, we want to feedback on, because that has certainly changed over the years. And I think quite a few years ago, there was such a small turnout for that, but now you're getting thousands of people feeding back, which is incredible. And I think that that's really important as well. So definitely at my level, we can support with that. But it's about, I think, sometimes having a bit of time and a bit of reflective time, because we're all busy clinicians, we're all busy in our roles. And then sometimes these are the things that are so important, but you just don't have the time to do. And I think we all need a bit of time to be able to do that as well. And I do think that we can support each other from a leadership point of view, but also I think it needs to be a meet in the middle relationship as well. And that's certainly what I'm trying to do locally, and trying to empower then the rest of the leadership therapy team to do. But there's probably a lot of work to be done outside of therapies as well.
Great, thank you very much. Andreas, and then I'm going to give Tim the last word.
Thank you. And thank you very much for the presentation. That was very, very insightful. A quick concrete question. Is it possible for non-execs to sign up for the active bystander training? A, I think it would send a signal that we take it seriously, and B, I personally would find it quite interesting. I'm sure I would learn something.
Great, that looks like a yes. Thank you. Excellent, thank you. Tim.
Thanks, Matthew. I've had lots of thanks, Rocky, but I'd like to have mine too, to everybody else's. And obviously we heard at the EDI committee some of the more of the details of some of the stuff that's been going on in therapies, which I think has been amazing. So thank you very much. I guess just a couple of things to highlight, and the EDI agenda in this organisation is huge. We know that in the staff survey, we do not do anywhere near as well as we need to be doing in terms of the experience that people have, and it is something we are absolutely committed to. It's important to recognise that EDI covers a significant range of issues, and the reason that we spend a lot of time on race is because it is such a big issue. Numerically, it is just huge, and we have to get that right. That's not to say that we are not focusing on other areas of the EDI agenda. We absolutely are, and there's some really good stuff that's been done around that Kevin's been leading around disability and getting reasonable adjustments and centralising the funding for that. So it's a big agenda, and the thing that we agonise over, I think, in terms of actions, is what's the right timescale in order to see impact. Because it's if you're not seeing impact after 3 months or 6 months or a year, is that because you've got the actions wrong? Is it because you've implemented them poorly, or is it because they were just wrong in the first place? And I think the point that was made earlier, which I think is a really key one, is that I think Sim made it, which is how do we get people to engage with this agenda? Because I think one of the issues is that people have dealt with it for so long that they feel there's no point in engaging with it because it won't change anything. And so I think that one of the challenges for us this year is to focus on some real things. Two things. I think the first is we have to be absolutely consistent about this, so that over a period of time, people realise that we are taking it seriously and that we are absolutely committed to getting this right and making improvements. But the second thing is, and I do think this is an interesting thing that we need to go back and really focus on, is some of these things, particularly around racist abuse by staff and patients, is if they see us taking very clear and firm action, and we are very clear about what action we are going to take, that does send a signal, and then I think will allow us potentially to engage with more of our staff because they actually think it may be worthwhile engaging. And I think that is one of the key challenges for us over the course of the next, I guess, 3 to 6 months. So I think it's been a really, really helpful presentation. Thank you very much, Ryan.
Brilliant. Thank you. Well, thank you so much for your time, Rocky. I think the point Tim made right at the end there is the one that's burning on my mind, is doing things behind the scenes is great and supportive, but if we're not seen to take action, then how do you give staff the confidence to speak out if they and actually have something done about it? And if we've got racist members of staff, we need to deal with those, and the people who are on the receiving end of it need to be confident that if they speak up, we will side with them to go deal with this. And I think if we can build that confidence, then we can build a path forward. So thank you so much for your time, Raki. Thank you for coming in. Thank you for everything that you're doing.
Thank you. It's been a pleasure. Thank you everyone for listening. I appreciate it. Thank you. Bye-bye.
Bye-bye. Excellent. Tim, Chief Executive's report. Let's come across to you.
Thanks, Matthew. I will just rattle through this if people don't mind. So starting with operational performance. So numbers of COVID patients have continued to reduce, which is obviously a good thing. But we do still have a small-ish number of patients. We do now need to think about how we work with that continuing number of patients whilst we deal with all of the other operational challenges. We know that our emergency departments are still very busy, and I think that it will be interesting to see to what extent that settles, and to what extent there are different patterns of behaviour from people in terms of how they seek their healthcare. I think that it is really important now. Obviously, this week the NHS reduced its level of alert from a national emergency level 4 to level 3, which is something that can be dealt with regionally and locally. And we do now need to think about how we really focus on getting our operational performance to where it needs to be in order to get through the backlog. There's been some good progress in the course of the last month or two. We've managed to get the 2-year waits down very annoyingly to 1, but hopefully it will be 0 this month. And the endoscopy team have done a really good job of meeting the diagnostic standard for the first time in April, which I think are 2 good examples of how the teams are working really well. But there is still a huge amount to do in order to get the elective performance, particularly in terms of day cases and operations, up to in excess of 100% of where we were in 1920. And the key thing of that is these incremental changes in our COVID measures. So there is now a significant change in the national guidance, and we do need to make sure that we implement that. So we will be moving towards using lateral flow tests on the day of elective procedures rather than PCRs, which will give us an awful lot more flexibility, I think. And of course, we've also need to update our visiting policy. I am absolutely committed to making sure that we get the visiting policy as liberal as it can be, because we absolutely appreciate the importance to people's recovery of being able to have family and friends visit them. I think the area where that will be most problematic is likely to be the emergency departments, because as people know, the emergency departments are in our organisations are very small physically for the number of people that go through them. However, there's been a lot of attention on ambulance handover times. The teams have done a really good job in maintaining good ambulance handover times, with Charing Cross consistently being the best performer in London and St Mary's doing very well, given that it is the busiest major trauma centre in London. If I move on to, there's a note in the paper about the flu vaccination campaigns. I think people did pretty well, and we're heading towards 90% of all of our staff having had the booster. Happy to take questions on that. In terms of money, The end of the last financial year, we reported an £83,000 surplus against a break-even plan. People have heard me say landing a break-even plan for a £1.45 billion organisation is slightly like landing a jumbo jet on a postage stamp, but I think that is a really good outcome, and thank you to all of the teams who have driven that. And indeed, in terms of our capital resource limit, we managed to spend 99% of it, which again I think is a very good effort, particularly as there was a lot of capital that became available in the second half of the year. So Hugh Gosling particularly and his team have done an amazing job to get the programmes through and to have got so close to spending 100% of it. We have submitted a plan for this year, which I think is challenging both operationally and financially, but I do think is achievable. And I think it is important that we do set ambitious targets, because again, there are a lot of people waiting for treatment, and we do need to make absolutely every effort to make inroads into that. The funding streams for this year remain moderately complex, I think, in relation to being a sort of a block contract with some incentivisation through the Elective Recovery Fund. But I think we have worked out a plan which I think will which is deliverable and sits within the ICS plan. At the moment, we are forecasting a small deficit around the inflation around utilities. In terms of Ockenden and maternity, you'll see the notes around maternity. We have been through the final Ockenden report and completed the benchmarking exercise around the 15 immediate and essential actions. There are some things that we do need to really focus on, and there's further information about that on the agenda item in this meeting. Monkeypox, it's important, I think, to recognise both that it is an issue, but also that it is a very different issue from COVID. So monkeypox is transmitted by close contact. It is not a particularly infectious virus, and it causes mild symptoms and in many cases does not need treatment. But obviously we are looking after a small number of patients with monkeypox. They are presenting generally through the emergency departments and sexual health clinics, and we have been doing a lot of work to make sure that staff are very clear about how they need to handle patients who present with symptoms of monkeypox, and there is now national guidance around what both patients and staff should do. In terms of redevelopment, we are continuing to work through the master plan on all of our sites in order to make sure that as and when the National Hospitals Programme make a decision around their business case, we are able to progress at pace, because obviously our estate issues are significant. Most significant estate issue that we've had, obviously, in the last few months has been the problems with the Western Eye Hospital. We do now have a plan that will allow us to restore the full range of services there, hopefully later this financial year. We've had to relocate some services to mainly to Charing Cross in the interim, but we hope to be back there as soon as we can, and we've put an additional eye operating theatre at Charing Cross in order to try and again help get through the backlog, and we hope that when we go back into the Western Eye we will have created an additional operating room which will allow us again to continue through the backlog. Colleagues will note that we've also had an issue with the gynae day surgery unit at St Mary's, which had to close both of the theatres. We've now pleasingly reopened them. And finally, I would just like to spend a little bit of time on the research and recognition. So a couple of things. We were interviewed for the Biomedical Research Centre reapplication process at the beginning of April. The outcome of that will be known in June. I think it's an incredibly impressive statistic, I have to say. 14,084 patients and healthy volunteers recruited into 442 separate studies, and more than 850 studies open in the year 21-22. And I think that reflects the incredibly effective way that the Trust and the college worked together during COVID. We've had more portfolio commercial studies than in any previous year, and increased the revenue from those, which is good. And then there's been some really interesting research and innovation that people will have seen in various forms of the media, particularly the E&O Breathe programme with English National Opera and our respiratory physicians using singing techniques to improve well-being for patients with persistent breathlessness after COVID-19, which as a singer myself, I thought was fantastic. But you'll see a list of other things. We've talked about the staff survey. I mean, I think there were some good things in it. I think particularly it was good to see that we continued to have a higher than average engagement score in the staff survey, and indeed higher than average morale amongst our workforce compared with other acute trusts, which I think is positive. But there was a drop compared to previous years, as there was across the whole of the NHS, which I guess is not entirely surprising. But there are particular areas that we do need to focus on, and we've talked about EDI, we've talked about line management, and we are launching, as people know, the improvement through people management, which is really focused on how everybody who manages another person in the organisation should be approaching that task, because it is clearly an issue that we are not getting right enough of the time at the moment, and it is something that we absolutely need to focus on. And I think the issues around staff well-being, we have really taken on board a lot of work done. We've now, as people know, refurbished over 80 staff areas, and those projects continue, and this week we hope to be opening the sort of big staff areas at Charing Cross and Hammersmith, which will be areas where people can just go to relax, to have some food, have some downtime when they are on break. You'll note the stakeholder engagements there, and then I think really pleasingly, Juliet Albert, who is our specialist midwife, who has run a fantastic clinic specialising in female genital mutilation, which has been a really difficult issue, has been awarded an HEE NIHR Career Development Research Fellowship for over £250,000, which is fantastic. And 4 of the Trust's clinicians for the university have been elected to the fellowship of the Academy of Medical Sciences, which is the highest really honour or in terms of medical science research. So congratulations to George Hanna, Ian McLeish, Shirani Sriskandon and Tony Gordon. This is fantastic news, and colleagues will, I'm sure, be delighted, as I was, to see that Imperial College London came out top for research in the Research Excellence Framework assessment of this year. So I think important just to finish with those, because I think it does highlight why it's such a privilege to work here, because it's the combination of really genuinely trying to provide the best possible patient care, but also really focusing on that innovation and research, which is what will drive healthcare into the future. I'm happy to take questions.
Thank you very much, Tim. Any questions for Tim? Peter.
Thank you, Matthew. Thank you, Tim. Just a quick question about the vaccination programs. So, I mean, as you said, you know, we've achieved a 90%-ish uptake for the various COVID programs, but the flu program is still at 60%. Which is roughly, if memory serves, what it was pre-COVID.
Correct.
I suppose I might have expected that there would have been a bit of carryover from the COVID programme to improve the uptake of the flu programme. But I wondered whether there were lessons we'd learned from the COVID programme that could help us get the flu uptake up.
It's a really good question, Peter. I think actually somewhat, I would actually go say somewhat the opposite, because I think the issue at the time, I think, was all about perception of risk. And so I think that it was quite difficult to make the case that the risk of flu was as great as the risk of COVID, and you needed to have two separate vaccinations. They were not combined and couldn't be combined, and so people needed to come back on a separate occasion to have the flu vaccination. So I think that you know, there was quite a powerful narrative in the public domain that said that you know, because of everybody wearing masks, everyone being out and about, that the amount of flu in the population was much less than previously, and therefore it wasn't a worry. Now, of course, we were all sitting there being slightly concerned that as COVID dropped and all of the regulations relaxed, that you'd see some massive increase. Now, we haven't seen that massive increase, and I think we're probably now expecting sort of next year's flu season. So I think we were actually, honestly, I think reasonably pleased that we got to the same level of uptake that we did the previous year. But I do think you're absolutely right that there are lessons that we need to take away from the vaccination campaign for COVID, which will partly, I think, about the availability of vaccines, making it easy for people to book in, and quite frankly, the ability to record how we vaccinated people, because there's always a recording issue with these things. And I know that Shona and the team that masterminded that from the Medical Director's Office are going to try and collate those so that when we get into the next year's flu season, we have put them together.
Thank you. Andreas.
Thank you. Tim, also a vaccination-related question. I noticed the booster uptake is less than the sort of first couple of shots. And I wondered whether it's worthwhile having another push, or whether we should wait for the onset of autumn when it's actually more needed, and then really push. Because if people had the first two vaccines, there isn't a fundamental issue with having vaccinations, but maybe they were just, yeah. I just wonder how we should push that forward.
Yeah, I think it's a good question, Andreas. I will take that back and have the discussions with Medical Director's Office and the IPC team. My inclination, I have to say at this stage, is to keep our powder dry, and when we get something from the JCVI around what the requirements will be for the forthcoming autumn, to really focus on that. But I can see that Professor Redhead has put his hand up.
No, Tim, I was going to say more or less what you were saying, really, which I think we've got to wait to see how the immunity is held up, because it's held up actually very well when you look at ONS statistics and real life in terms of infections. And I think that the right time to do this is if we start to see an increase in the community acquired infections, then I think it would be the right time to start that booster campaign again, and also waiting for any advice from the JCVI about additional ones as well. But the boosters are still open to all our staff, and staff are still encouraged to come forward to getting those boosters when they want them.
Thanks, Julian. Okay, thank you very much. Thank you, Tim, for that. And I shall move us on. So moving on to item 10, the Integrated Quality and Performance report. Claire, are you going to introduce this for us? Or between you and Julian?
Thanks. Yeah, will do. I'll make a start and then I'll hand over to Julian. So this is the performance report for March, but I'll update it with numbers for April where we've got them now. And I'll just very quickly take you through a few of the headlines. So our elective and day case activity continued to increase during March. In fact, it was at the highest level since November, which was our peak following the second wave of COVID. And that upward trend is now continuing. And we achieved, actually, for elective and day case work, 90% of our pre-pandemic baseline for the year as a whole, which I think was a really positive result given the issues that we had with COVID towards the end of the year and the problems that Tim's talked about with Western Eye and needing to relocate some of their clinical activity. We did, though, have some problems with the way that we profiled our activity. So our performance against the trajectory in March looks, I think, poorer than it ought to have been. And what we've done for 22-23 is to be much more careful about how we've evened our activity out over the year so that we don't get these big peaks and troughs that are sort of artifacts of history. All of that said, as Tim's already alluded to, there's still a lot more we need to do to get ahead with our 22-23 plan. We know our April activity number for elective and day case work won't be quite where we wanted it to be, and we will be redoubling our efforts and making a number of changes around available capacity. Some of the things Tim's spoken to about infection control, and also just re-putting in place some of the processes that we had around before COVID hit, around how we manage our activity, how we schedule, how we keep a forward view on what's coming in to get our numbers up, to hit the plan, but most importantly to make sure that we're able to deliver the reductions in waiting times that we hope to over the course of this year as well. Just in terms of outpatients and diagnostics, we're back up or above our baseline activity levels, so we will continue to maximise throughput when we can. And we also overachieved in the last financial year in terms of our RTT clock stops, which was one of the measures that was introduced in the second half of the year. Just in terms of our overall waiting list, the waiting list size is increasing, and it's increased actually again through April. We're having a look at the reasons for that. We think that's predominantly around increases in demand as opposed to anything else. And what we will do now is start to forward forecast in terms of demand and capacity analysis to make sure that we've got enough capacity in the system to be able to achieve our waiting time trajectories. In terms of our very long waits, as Tim said, we had 2 patients waiting over 104 weeks at the end of March. They were both treated in April, and there's one patient waiting in April. In terms of our 52-week waits, we had more patients waiting at the end of March than we had anticipated, which was primarily the impact of some of the problems we'd had over winter. We will again be off track in April, but I'm expecting us to get back onto trajectory during May. Diagnostic performance, actually, the number of patients waiting over 6 weeks increased a bit during March. That was kind of just natural variation, not reflective of an emerging trend. And the 2 areas we were particularly worried about, being endoscopy and neurophysiology, actually delivered quite significant improvement. And for April, performance has improved again, and now it is the best that it has been for over 12 months, but we've still got some way to go to get back to delivering the standard overall. We're making slow improvements in cancer. We've got some trajectories. It's taking us some time to recover. Katie can talk more about it, but I think we're clear on what we need to do, and we're really focused now on making sure that we're able to deliver those trajectories for cancer performance as quickly as we can do. And then I don't really have much more to say in terms of urgent and emergency care than Tim's already spoken about. I would just flag that we continue as part of our North West London response to participate in some changes to the way that ambulances are conveyed around our sector, which means that St Mary's and Charing Cross are supporting some of our more challenged emergency departments by taking additional ambulances, and we will continually review that to make sure that we understand the impact both on the emergency departments and on waiting times for LAS as well. And ED waiting times are higher than we would want them to be, and our absolute focus for improving that is on discharge. On the topic of discharge, there were some questions at the last board meeting about what we're doing and how we're doing it, and so we've included some narrative about all of the good work that's going on in the paper. And we've also got Anna Bakobza, our Director of Integrated Care and lead for the discharge team, joining us for this item, just in case anybody wants any more detail about that. And that's all from me. Very happy to take any questions on operational performance, but we'll hand over to Julian to cover the quality piece.
So any questions for Claire? Okay, across to you, Julian.
Okay.
Oh, sorry, Kay.
So this was on the cancer wait. So is that you, Claire?
Yeah. Yes.
Yeah. So it was really great to hear there is improvement in the cancer, albeit slow. However, before the pandemic, we already had cancer inequalities, and this may be one for Katie as well. And it's just really can you be assured that the gap isn't widening? So, for example, that the long waiters aren't coming disproportionately from the most deprived postcodes or from certain communities, because it was, I think, all but one of our boroughs was worse than the England average pre-pandemic, and we just need to understand whether that is part of the slow improvement, or actually we've got yet another bigger mountain to climb in terms of cancer weight inequalities.
Katie, do you want to take that one, or do you want me to?
Yeah, that's fine. Thank you very much. And Kate, thank you very much for the question. So we've been working with RMP partners looking at.
Katie, you sound like a Dalek, I'm afraid.
I'm so sorry. I'll take it while I move on to a different device.
We
Might have to come back.
may have to come back to you, Katie. Let's, Julie, should we go on to you and we'll come back to that question after you're saying, give Katie a chance to get her headphones sorted out.
No, very, very happy to, and thank you very much. So I'm pleased to say that.
Sorry, my apologies.
sorry.
Andreas wanted to jump in with something. Let me just pick up on it.
Thank you. Thanks a lot for the presentation. Just going through the tables, it looks, but maybe I'm misreading it, that a number of our sort of performance metrics are sort of trending in the wrong direction. And I just wonder whether I'm reading too much into it, or whether there is something that we need to sort of turn around a bit more.
So my overall summary would be, I think that for the RTT metrics, we are there's an issue about demand, which is driving the PTL size, but actually we're chipping away at reducing the waiting times, and I'm expecting those to start to come back in line from now going forwards. And I think the performance currently, or for March and April, has been a legacy of some of the issues that we had with COVID in January and February, which put us a little bit behind track in terms of where we'd wanted to be. I think urgent and emergency care is absolutely a work in progress. February and March were really very difficult months. Performance looks better for April, but what we absolutely need to do is focus, as I said, on our discharge process and make sure that we've got all of the performance review mechanisms in place that we had prior to the pandemic, to make sure that we're all of those tiny changes that we can make that are going to improve performance we're doing, and we're absolutely driving through. And I know Francis does a huge amount of work to support that alongside me, and as I say, in April it seems to have delivered some improvement. So I think it's a fair reflection to say our performance is or has been very challenged, but as I start to look forward to the coming months, I think it is going to get better, but it's going to be a long slog for us to get there, given the scale of the challenge we've got ahead of us and the pressures we still have around the front door, whilst also balancing trying to do more elective work.
Thank you. Katie, should we come back to you and give you another crack at the...
Sorry. Is that better? Can you hear me?
Perfect.
Yeah, okay. Sorry, I'm so sorry about that. So for the sector, we are working with RMP, and we've done some work looking at inequalities. And you're right, Kay, that places like Hillingdon and Brent do have very poor cancer equality targets. That is driven really by their local cancer services and their diagnostic services, which we're working hard to support through their one-stop shop and their diagnostic hubs in the community. For our long waiters on our PTL at the moment, when we've looked across, for the ones who start with Imperial, there is no difference at all between age, sex, or any other protected characteristic. That we know that our long waiters are held in particular cancer groups, but we don't have any protected characteristics inequalities. We do see, and we are seeing, a rise in late transfers from places like Hillingdon and Northwick Park, and we are working with them to try and speed up their diagnostic pathways, which is the best way of decreasing those inbuilt inequalities. But a lot of that work we're supporting through RMP. So, for example, the early diagnostic lung bus, that's based at Hillingdon for low dose CT scan for lung cancer diagnosis.
Okay, let me come back to you and then we'll move on.
Yeah, I suppose I don't think deprivation quite goes into protected characteristics. So it will just be, maybe this is something to explore in future, is about the sort of almost the postcode analysis, just as that sort of additional check, because but it's great to hear that the work is going on in those boroughs, and I think that community approach will be really valuable. But I just wanted to make that point that it's not, deprivation isn't quite the same as the protected characteristics.
Right. You're absolutely right. So once they're into us, we don't see any difference. I mean, literally, we're scattered across our particular areas, but we do see the deprivation index is particularly marked on referral into a diagnostic pathway. That's the biggest. Once they're in a diagnostic pathway, they seem to be progressing okay, and particularly here with our navigators and our CNSs, we don't see a very high dropout regardless of postcode, but it's getting into and accessing that diagnostic service that, yes, we do see a spread between postcodes.
Thank you. Julian, let me come to you.
No, thank you very much, Matthew, and colleagues. So I'm pleased to say that our incident reporting rate has increased following the focused work that we've been doing around that, and our relative harm levels remain low. So that does put us in the right place, which is a high reporting institution, but with low harm levels, which is exactly where we'd want to be. Our HSMRs and shimmies also remain low, which is a good thing. The bit that you'll see in the papers is around our relative position against other trusts, where we have slipped out of the top 5. And that's something that's sparked us to have a review of that. But I hasten to add, this is not to do with any changes in our HSMRs, it's our relative position. So we remain a very safe organisation from that point of view. We have had, unfortunately, a never event which has occurred, and this was relating to the use of insulin out of an insulin pen and then using that in a normal syringe, which unfortunately has a dose calculation around it, which is why it's a never event to do that. Obviously, my concern around this was we had a similar event 2 years ago, and a number of actions were put in place at that time. Obviously, we reviewed those actions to make sure that they did occur and were robust, and we're looking now at further actions around more education and training around diabetic management as a whole across the whole trust, trying to take this learning into a wider context as well. But I would hope that that would make sure that we don't have another never event of that similar nature. The other aspect just to highlight is the bloodstream infections, where we've had another bloodstream infection from MRSA, and colleagues remember that our ceiling for this is 0. So that does take us into, again, a difficult position. Now, we had in 2021, you remember we had a cluster of these around paediatric haematology. I'm pleased to say that no further events have happened after the actions we took in that area, and none of these BSIs have been repeat areas again. So again, we're looking at a much wider aspect of how we train and help our staff around the management of lines, both at insertion, but also their ongoing management to prevent these bloodstream infections occurring into the future. Those are what I was going to highlight on today, and I'm happy to take any questions.
Any questions, comments? Peter.
Thank you, Matthew. Julian, could you just say a little bit more about the repeat never event?
Yeah.
Which is obviously quite concerning to hear about, in that obviously we thought we had got at the root causes of the never event the first time, and apparently have now discovered that we hadn't. So my question was not so much about this specific never event, which I'm sure the team is getting to the bottom of, but whether there's a more general lesson here for whether, when we think we have addressed the root causes of an issue like this one, we have, or whether we have some blind spots that this incident has revealed.
No, thank you, Peter. And obviously that's an area that we're reviewing, because a couple of their events have been repeat ones, and that always concerns me when we think we've taken those actions and have we followed and made sure those actions have been followed through. And I've had some assurance that that has occurred from the first one. And I think that this particular one is around human error in terms of knowledge base of people not to do that. And making sure that everyone is aware, and we've got a culture where people are questioning and asking questions as to why you're doing that when it's not an ever event as well. So I think there's quite that to me would be the wider issue, is around the culture, to make sure that we're able to challenge each other, and that we're getting the ability for everyone to be watching each other's backs to make sure these things don't occur. Obviously, we're also using these as opportunities to review other never events. And we're also working as part of the system now as well, so part of the ICS, so that we're getting information through from the never events which occurred across the ICS, so that we can again learn from those and try and prevent things which are occurring, which may occur to us, which have occurred in other institutions as well. So it is sparking a much wider review, and certainly the learning from this one we've put out across the whole ICS, so that the whole ICS understands that we've had that never event, and make sure that they're reviewing their practices as well.
Thank you.
Thank you, Julian. Can we move on to your next item then, June? Is there anything you want to add to your infection prevention and control report?
Only very briefly, thank you, Matthew. It's a quite an in-depth document, and I think I'd like to start by just by highlighting the work that the infection prevention control team have had to do, both in terms of COVID and now monkeypox, and ongoing challenges all the time through this. And they've really worked very, very hard. And this board assurance framework, I think we've used in the correct way, and has actually been really helpful. And colleagues will remember that this started as a sort of a relatively small document. It's now got 125 clauses over 10 domains, and doesn't just cover COVID. But we've used it to make sure that we're RAG rating ourselves correctly against this, so that we can look and show improvement, but only showing green where we've actually got the evidence for what we've achieved as well, going back to previous points, to make sure that we have got those bits closed off. So I'm pleased that we have no further reds, and colleagues remember we did have reds when this process started. Our ambers have decreased. We've got 16 ambers in place at the moment, and 3 since my last report have gone from amber to green, which I think is the right progress and the right rate of progress as well, because some of these are quite complex, these closes, but important areas that we are making progress in.
Thank you. Any questions? Peter, have you got, is that your old hand up, or have you got a question? Thank you. I suspected. Anything for Julian? Otherwise, we will. Andreas.
Sorry, just on monkeypox. I mean, it's not very infectious. It's very mild. I mean, why does it get all this attention? Is it because it looks pretty horrible and makes a good Instagram feed, or is there something I'm missing? And is it a distraction rather than, I mean, something really to worry about?
So, Andreas, I think this is to do, it's to do with public health, and at the moment it's classified as a high consequence infectious disease. And there is a small mortality rate associated with it, between 1 and 10% in Africa. And obviously that we would expect to be at the lower end in our own healthcare systems. I think the issue is around trying to make sure it doesn't become endemic in the country. And I think that's why there is such a consequence to this, and trying to prevent further spread. So if we can control it and keep it out of the country, because it's not like COVID, it's not so infectious, we've got a reasonable chance of doing that. And that's why there's been concern. Obviously for us, that's because we therefore have to admit a number of patients and isolate them, and making sure people go through isolation procedures. And obviously there's a lot of worried well out there, which causes us the issues operationally. But in terms of trying to make sure this doesn't become endemic, I think that is the right thing to do for the country.
Thank you. Well, thank you very much for that, Julian, and good to see the indicators going in the right direction, and it's a good report. So if I can move on to item 12, the Ockenden report, and TG, you're going to introduce this for us. Thank you.
Thank you, Chair. Thank you, Trust. This Ockenden report is a review of 1,592 clinical incidents and interviewing 1,486 families of incidents which occurred in the Trust from the year 2000 to 2019, where it showed serious failings which resulted sadly in increased maternal and fetal morbidity and mortality. This has resulted in 2 reports labeled the Diana Ockenden report, first published in December 20 and the second part March 22, of which showed that there were 7 immediate and essential actions from Ockenden 1 and 15 from Ockenden 2, totaling 92 individual action points. These have been grouped into 4 pillars of safe staffing levels, a well-trained workforce, learning from incidents, and obviously listening to families. This report has been shared with our maternity staff by several engagement events, which will continue to June, and it was in fact attended by our CEO. This paper here addresses the gap analysis of the immediate and essential actions from not just Ockenden 1 and 2, but from the previous Morecambe Bay report and the maternity self-assessment too. And these addresses where we are in terms of compliance. For ease of review of this paper, they have been color-coded in relation to the 4 pillars outlined and highlights the outstanding actions, but all these outstanding actions have a date for it to be addressed. This paper also addresses the continuity of care model, which a lot of us feel is the best model to deliver maternity care to all our patients. However, the caveat here is that this continuity of care model is challenged by the workforce constraints, which we all know in London there are about 1,000 midwives lacking at this present time. There is a projected timescale for this C of C care, and I must actually compliment my head of midwifery for addressing this by directing whatever so-called continuity of care model groups we have to serving women in the most deprived areas in our patch. So this paper basically gives the public and the trust board assurances that we are committed to achieving compliance for all these action points, which are required by the reports. And on an ongoing basis, they'll be monitored by the governance of the EMB quality, the Trust Quality Committee, reporting to the Trust Board. I'm open to questions.
Thank you very much, TG. Kay.
Thank you. I just wanted to talk to this as the maternity champion. Somebody's TG, I think you might need to mute. Yes, so I was going to talk to this as the Trust non-exec maternity champion. I think it's really, I mean, this is an incredibly important item, but I think it's also important to acknowledge the Trust's focus on providing excellent services and improvement before Ockenden. We're sort of very focused on Ockenden at the moment, but TG and I were talking, one of the reasons that the maternity services received outstanding from the CQC is not because everything's perfect, but because there was demonstration of being a learning service. And I think that's the really important thing not to lose sight of here. Of course, this has given us more insights and areas to explore. And I have seen a huge amount of work from the team since the first report in December 2020. We might not have done a lot for sustainability with the amount of trees that have been knocked down, with the amount of papers that have been produced, but part of that is there's been some really active discussion, challenge, and continuous improvement activities, and not just about Ockenden. You know, we've had very sort of spirited debates about lots of issues. You know, for example, there's some publicity recently about poorer outcomes from women in ethnic minorities. That was discussed. We continue to sort of take that wider view. And as TG has said, you know, the maternity teams are in the middle of the Ockenden engagement sessions. There is a programme to look at, can we learn even more from patient feedback, which I feel, as some colleagues know, the reason I came in and got my first NHS board role was because I had a poor experience, a very, very poor experience in maternity services. So I feel very passionately about this, and there's real commitment there. And even more deep dives. So, you know, if you are an NHS non-exec, one of the things you might do is read reviews of all the things that have gone wrong. And it's usually because there might be complacency. And I think the overriding lesson is not to be complacency about quality. And I've seen a real openness to all my sometimes daft questions, which I think sort of shows that there's that culture and willingness to learn and improve. There's still a long way to go, and we will still need to, and I think TG's warmed, it might even get more complex, but I think it was just important. I did a lot of reflection in my role, it's a very tiny role over the last 15 months. And I just wanted to share that because I think it's important to take it in a sort of holistic way rather than sometimes the slightly reductive tick box way that reporting at board might mean we do.
Thank you, Kay. Thank you very much indeed.
Thank you, Kay. Yes. Anybody else like to come in on this? Any other questions or comments? Andreas.
Thank you. Tim, taking it beyond maternity, if you look at what were some of the driving forces behind the poor outcomes, how can we make sure that in other pockets of the trust we potentially don't encounter similar behavior patterns or belief systems, etc., that we look and shine the light, that we don't fall in the same trap in a different area, but similar reasons?
It's a really interesting question, Andreas. I think that some of the things are so some of the things are related to what happened at Shrewsbury and Telford, and indeed, at a number of other maternity units across the country, are actually quite connected to the specialty itself, actually. So. And I was very struck by the regional midwife for London making the observation that midwifery and maternity is a very complex dynamic because of the importance of making sure that the woman's views are always taken into account and she has the right experience, but also has the right guidance. And so what might be right for one woman in a specific circumstance may not be right for another woman. So I think that there's that level of complexity in terms of midwifery is it's reflected in other parts of medicine, clearly, but it is quite specific. And if you then add into one of the other issues has been historically poor relationships in that organisation between the midwifery staff and the obstetric staff, so the midwives and the obstetricians. And of course, a maternity unit can only work effectively if there is a good connection between those two. And again, it's a very specific set of relationships that relate to the maternity services. And I think that, the other thing that you sort of referred to is the issue of dogma. And I know that there's been some correspondence recently amongst colleagues around how can we be sure that there isn't a particular dogma that is sort of besetting our staff about a target. And I think it comes back to that every woman is unique in the approach, and therefore it is not appropriate to have targets. You do need clearly to look at the outcomes, and you do clearly need to look at whether you are very much an outlier from national practice. So, for example, if you look at home births, are we as an organisation advocating too many, for example, home births? No, clearly not, because only 1.5% of our births are home births. I think that there is work to do, and I think this is part of the ongoing work around making sure that we have understanding about how people are interacting in a more qualitative way. So we could look at the metrics here, but this is an area where I think we will need to get more qualitative data about how things are going. So much of that, of course, is maternity specific, and I'm sorry this has been a rather long answer, but I think we have good processes in place across the trust generally for people to alert us when there are problems, and when there are relational problems, I think, again, we've got a suite of metrics for most things now that allow us to see whether performance is in line with what we would expect it to be, and whether or not individuals are problematic. And certainly in many specialties, and Julian will, I'm sure, say something in a second, we've been able to identify with specific clinicians if there have been problems where it looks as though their practice is out with what we would expect for their individual specialty. So I think in many specialties, particularly actually the surgical specialties, we've got some quite good mechanisms for picking that up. And obviously what we need to continue to do is to triangulate those data with information we're getting from whistleblowing, from the freedom to speak up guidelines, from all of the different sources we have that are telling us about how services are working.
So before I turn to you, just picking up on the data point, one of the other boards that I have the joy of chairing presented a report which said that they had typically 2 or 3 reportable incidents per month, which was slightly lower than it used to be in their maternity unit. When I first looked at it, I thought, well, that's good, it's going down, and that sounds like not very many. And then I realised I have absolutely no idea whether that's very many or not, because there was no benchmark against it. And the part of the opportunity we have as the collaborative, I think, is to start counting things like this in a common way across ourselves, and at least make sure that we are holding ourselves to account as the best that you see in North West London, and sharing that learning and teaching to help us get to that point, so we're getting one view across all of our providers. And the other point that I think is extraordinary about Ockenden is that we generally take the view of some of these incidents, like a baby death or a mother's death, that it is so rare, but it occasionally happens, that you can't see it in the data. Like, it will happen occasionally, and that doesn't mean the service has suddenly gone really badly and that it shouldn't happen for a long time. That's not true about what happened at Shrewsbury and Telford. Those numbers should have been visible in the data, and I'd like to be at least sure that when we're looking at the data, whilst we should investigate an individual incident, when you start to get multiples of it, we ought to be able to see that in a dashboard, and nationally we should have been able to see that, let alone locally, and just to make sure that we are what we're seeing is data that's within the confidence interval of nothing to see here other than investigate the individual incident rather than a trend. And I'm confident this organisation's in that place, but we want to always be confident in that. Julian.
Yeah, no, thank you. And just to expand a little bit on what I think you're both talking about, and then a separate point as well. But because we do look at, obviously there's GIRF, there's national audits, there's CQC insights, there's peer review, and there's now the ICS data as well coming through, which allows us to get those comparisons and bring that data together. And that's something we're already doing in terms of our quality insights that we try and do around specialities, so that we understand if those issues occurring. And then a separate point, but related, so I think one of the big learnings that we're coming out from Ockenden and is around how we respond to complaints and how we involve families and support our families during complaints and instances. And there was a very complex complaint that we discussed at the Quality Committee, and our response to that, and we're trying to use that as a very much a learning platform to how we can improve our response to those things as well.
Thank you. Any other questions or comments? Thank you. Oh, Peter.
Thank you, Matthew. That was deliberate that time. Just a reflection on what the conversation that you and Tim and Julian were having about, what excellent looks like in this area. Because obviously, as you say, avoiding death, or avoiding death that is unavoidable is a necessary and important condition that we meet. But for me, the question is, well, what's the next frontier? And we've talked before about having a better, more comprehensive understanding of patient feedback, which complaints are obviously an example of, that you just mentioned, Julian. There's also the whole use of outcomes data in as regular practice. And I'm, for example, struck when talking to people on wards who work in the hospital, very few of them understand what the outcomes are, the long-term outcomes are of the patients they treat. And so, I mean, this is a big question, which, I mean, I'm sure it's not answerable here. But for me, the question of where we take this so that we can be sure we're delivering the best outcomes in the round, as opposed to avoiding bad incidents that obviously we all wish to avoid, and how we build that into the culture is, I think, an important forward and future-looking priority.
Thank you. I'm going to come to Tim, and then I'm going to give TG the last word.
It's a very interesting question, Peter. So a general point first and then a specific point. So one of the things that, as you know, that we're doing this year is to create a user insight function, which will pull together all of the information that we're getting so that we can triangulate much more effectively what we're getting from friends and family, from complaints, from stakeholders, and actually from staff about what they're saying to us about our services. And I think that will be very helpful in which we can then again triangulate with some of the harder metrics, which we're probably a bit better at looking at in terms of, as you say, mortality and sort of the rather harder outcome data. And I think that will be very helpful across actually the whole of the trust, not just maternity. For maternity, I do think there's a specific thing which I think you're right. We would all, I think, agree that the team did a fantastic job to get an outstanding rating from the CQC. But as Kay said, we would all agree that we do not have the perfect maternity service. There's some very innovative work there, and but one of the things we have not focused, I think, sufficiently on actually is how we is what are the mother and partner's experience of our service. And I think if you look at the patient survey, we are not in a good enough position, in my view, at the moment. And I think what Julian's just described about really using some of the feedback we're getting from our service users to improve things is the next thing. Because as you're absolutely right, avoiding avoidable death and harm is a really, really important thing. But probably for maternity, more than many other services, the experience of using the service is really important. And of course, that is part of the thing that will drive people either towards us or away from us as a service. So I think it's a really important thing.
Excellent. Thank you, Tim. TG, do you want to wrap this up for us?
Yeah, yes, very quickly. In fact, Tim has echoed and Julian has echoed how we make ourselves even better. The learning culture must persist, but the learning culture would be directed at two fronts. One is, as Tim says, the care and the feedback we get from patients in terms of the compliments, the friends and family tests, and very importantly, the complaints. And we're getting patients involved in how we respond to complaints, whether it's something that they feel is appropriate. The second most important group is our own staff. We have to make sure that our staff actually enjoy coming to work and delivering care. And as in our survey, we always strive to get better. So I think the concentration would be on two, patients and our staff. Thank you very much.
Thank you, TG, and thank you for the report. And I've no doubt we will be coming back to this periodically at the board in the months to come. So we look forward to discussing it further. So moving on to item 13, the cheerfully titled "Learning from Deaths." Julian, anything you want to pull out of the report?
Again, I won't go into huge details because it's in the paper, but just to highlight the really good work that those involved in this process have developed, and the leadership around that, and the colleagues who are undertaking these structured judgment reviews. And I mean, the next stage is to roll this out not just within hospital trust deaths, but now into the community as well, which will not be another big ask of those teams, but I think important so we get a full picture of what's happening to our population and our citizens and learning from that as well. I think we've developed a really good, robust process, both for the SJRs and how we also review them and use that information. And we've got evidence now that how they are feeding in to trust priorities around quality. And one of those cases is around dysphagia, which was identified through this process of learning from DES. And now we're going to have a focused improvement program around that. So I think there's a really good link now between how we've got a robust process to identify issues, how we use that information for improvement is now as part of this second part to that. I'm very happy to take any questions.
Any questions for Julian? Okay, thank you very much, Julian. Thank you for that. Moving on to the board summary report from the Quality Committee. We don't have Andy here today. I think, Bob, you were probably, or Peter, is this, which generation
sorry,
hand
Matthew,
is this?
I was a bit slow on the draw there. Yeah, just a quick question for Julian. Julian, in the report that you talk about one death where the care delivered contributed to the death, and another one where death followed from a recognized complication from the treatment. I was obviously very concerned about the first one. And I wonder if you could just say a little bit more about what we've learned from that.
This was to do with this was to do with this dysphagia case that I was talking about. This is where people have difficulty with swallowing, and how we identify and how we care for those patients. And that was that focus, and that's where that learning has come from. So we're now doing a focused piece of work across the whole trust to make sure that people are aware about how we care for people with dysphagia, and making sure they've got the correct assessments, and that those assessments recommendations are being followed through, both while they're an inpatient and as they go out into community as well, Peter.
So was this a case where we thought we were doing the right thing and it turned out to be not achieving the outcome we thought it was? Or was it where, for some reason, the care that we delivered was not what we would have expected to deliver?
Unfortunately, it's the second one, and that's why I think that's an important focus for us to educate, learn, and make sure we've got robust processes.
Thank you.
Thank you, Julian. Any more questions for Julian before I move us on? Great, thank you. So the Quality Committee board report, we don't have, is there anything that either Bob or Janice or Julian, who I think are all at that committee, want to draw to our attention? Otherwise, go on then, Bob.
Sorry, just quickly, Matthew. Obviously, you can see from the comprehensive nature of the report that much of what the Quality Committee discussed, we have gone through at board level just in the past sort of 15-20 minutes. I would particularly draw the board's attention, though, to the deep dive on dealing with mental health patients in our EDs, which I know colleagues have been concerned about over some period of time. It was a good conversation, and recognising completely that often those circumstances are not at all appropriate for the patients. We were very keen to disaggregate those things which we need to ensure we do the best we possibly can for those patients in those circumstances, but also our obligation to make absolutely clear to fellow providers of mental health services and commissioners of mental health services that this is not something that we would want to see. At some point, action has got to be taken on a wider platform, and the deep dive was very good in isolating that. And then I'd also reiterate what I think I said before, was we agreed further important deep dives in areas that this committee was particularly concerned with, and that doesn't come out fully in the update report. And ambulance handovers was an absolutely key element of that.
Thank you, Bob, and thanks to the committee for looking particularly at that issue, which I know is a matter of concern to the board and is a subject that I've discussed with the London Regional Director last week. And I know it is high up on the London region's level of concerns as well, is making sure that the right and timely support is available for mental health patients who turn up in an acute A&E, and that they get their care from the right professionals in the right place as quickly as possible. So thank you for that. Any other questions? Otherwise, I will move us on. Thank you very much for that. So moving on to finance. So finance report, Jazz, over to you.
Thanks, Matthew. Hopefully I won't repeat a lot of what Tim said, but just the key highlights for me are, as Tim did say, we did end the year with an £83,000 surplus against a break-even plan. And a huge thank you to everybody that's contributed to us getting to that position, because it is hard to manage that number, but we got there successfully. In terms of capital, as Tim also mentioned, we've got a short undershoot of about 600,000, but we are subject to receiving final confirmation of our capital resource limit, and that number may change, but a draft position, that's our understanding. In terms of cash, as colleagues will see, we've got a quite resilient cash position at the end of the year. However, a lot of that is to do with timing of payments and income, and that is expected to go down as we start to settle some of those payments in 22-23. In terms of our better payment practice code performance, there's a 95% threshold, and we do consistently perform better than that. So I'm pleased to announce we are trying to make sure we pay our creditors in a timely manner, and that doesn't have a detrimental impact on the delivery of services. And the last final point was, as colleagues know, we were transitioning the Chelsea and Westminster NHS Foundation Trust payroll over to Imperial, which we successfully landed on the 1st of April and are now serving that population of staff as well. So those are the key highlights from me. Thank you.
Thank you. Any questions or comments? Okay, thank you very much. And Jazz, Peter, we've got a delegation that we need to approve. Do you want to just?
Yeah, thank you. Thanks, Matthew. So as we're talking about year-end finances, we've obviously got our annual report and annual accounts that need to be submitted on the 22nd of June. What we have in previous years successfully done is for the board to delegate the authority to the Audit, Risk and Governance Committee to go through the details of that, so that we don't need an additional board meeting here. So Audit, Risk and Governance Committee, if Kay's happy as chair of that, will do the scrutiny on behalf of the board of those accounts and of the annual report, taking into account the auditor's comments, and approve submission of those accounts.
Thank you. So that's a recommendation. Does anybody have any concerns with that? Good, thank you. That's agreed. So moving on to the Finance Committee report. Andreas, is there anything you want to pull out for our attention?
No, I think it's either been discussed or in there.
Thank you. Any matters that any members of the board want to raise? Otherwise, we will note that report, and we will move on to the People Performance Scorecard report. Kevin.
Yeah, thank you. Just a couple of things to add to what's in the report is you can see that we've added some SPC charts that gives us a bit more of a longer timeline, so you can see some of the trends. And I think whilst some things might not be technically special cause, you can see a pattern where the staffing metrics fit with some of the COVID waves, and I think you can see the impact there. We often talk about vacancy as one of the main metrics, but I think if you look at staffing post and their establishments, the stickiness on vacancy is not just about turnover, it's also about our establishment is growing. A lot of the time for legitimate means in terms of research and other expansions that are legitimate. And so we're not quite keeping up with our recruitment to get that vacancy rate down, and so that's what we're working on. There are some successes in nursing, but it's still challenging out there for nursing. We don't forget that. The other area I would just highlight is at the bottom of the scorecard. We have some local metrics around EDI and particularly the workforce band 7 and above. So you've heard before us talk about the interventions that we're taking. We've reviewed some of those interventions to try and adapt them slightly. And following the workshop that we had with Roger Klein, who's one of the experts in this area, we're also looking at some more significant changes about the way that we recruit and select people, as well as improving our current ways of recruiting and selecting. And also more work on talent management and stretch initiatives for people from BAME backgrounds that are more senior. So we've got some more work to do there in relation to that metric, but I'll just then probably just take any questions on the rest of the report.
So questions, comments, Bob?
Thank you, Matthew. Kevin, it's not so much a question about the report per se, but obviously you talk in section 3 about temporary staff spend, and it's key at some level in flexible working. I just wondered for your view on the new national restrictions on levels of temporary staff usage. A, how you saw the implications of that, and B, what additional controls you'll need to bring in to ensure adherence.
So I think part of what we're doing is trying to get better real-time data about where we're breaching certain pay caps, and we're doing that across the acute collaborative, and particularly looking at medical workforce, and trying to perhaps look at how, when we're escalating and signing things off, that we have those controls in place. And then the other part is obviously continuing to try and fill those, particularly the high volume but the hard to recruit posts, so that we're trying to manage the market more, because we're too often getting into a position where, you know, for patient safety, we can't do anything else but pay for somebody at an escalated rate. And also we're sort of, again, sort of almost competing with each other for those people, and they're trading us off against each other. So we've got a medical staffing improvement programme across the 4 acute trusts, and this week we're going to be looking at who's escalated the rates for which specialties, at what grade of doctor. We have better data for the nurses already, and it's not so much escalation there, it's just the volume of vacancies that mean we have the problem there. And then it's the AHPs and some of the scientists where we know that we're, you know, struggling, and therefore it's sort of grow your own, but it's a long period.
Okay, thank you.
Thank you. Kevin, can I ask a question about staff induction? The numbers are very low, and probably very good reasons during COVID about how kind of the machinery of making sure every staff receives proper induction as when they start will have broken down during that period. But we are now, I think the thing report is about 2/3 of staff are receiving a staff induction, and I mean it's very important for 2 reasons. One is to deliver the culture and the values and the expectations of the organisation, and the other is delivering important governance messages about information governance and patient protection and all of those sorts of things. So I just wonder whether you have any words on kind of the plan to get that back from 2/3 of staff and back up towards sort of 95% as the target we've set.
Yeah, and I think the target reflects where we were pre-COVID, because you know, you set a target of 95%, that's there, and we've generally been achieving that previously. So we do know where those areas are that, you know, we've got the data to know which areas are not doing that, and so that's really a focus piece of work with the divisions on getting it better. And some of it is about recording it as well as it happening. Yeah, I'm confident that if we can have a clear run of, you know, a few months without, you know, COVID, VCOD or anything else, then I think we've got the systems to bring that back up, I think.
And will that include going back over the people who've been missed? Because there's some people who haven't got the important stories that we want to tell them.
Yeah, so they still register as not having a local induction, even if it's like 2 years later.
Right, okay. Thank you. Tim?
So I just wanted to be clear, this is local induction as opposed to induction. So they will have done the values, they will have done all of the information governance. This is about going to the individual area inside the organisation where you're going to work and getting a sort of induction in that area. Because the reason we put it as the scorecard is it actually was an area where we have traditionally rather struggled to get, and part of it actually is recording of local induction is quite patchy. It's a real focus for us at the moment actually, because we're focusing on a lot of the discharge work and getting the board round work done. And one of the key things there is everybody understanding in their local area what the mechanism is for getting those things done. And so actually there's a renewed focus to get that right. So hopefully you will see the numbers go up.
Okay, that's helpful. Sorry, I misunderstood. So are we confident that there's 100% coverage of corporate induction?
Corporate induction is much closer to 100%. I wouldn't put my hand on my heart and say it's exactly 100%.
It's a lot better. I can get the data. The reason it's not on the scorecard is because it's one of those things that we're maintaining at a very high level. But I will double check and get a actual figure and
just confirm that that's still true postcode. Yeah. If it's still coming in at 99.9%, you don't need to add a line to the if there's a bit of recovery there, then it would be useful to be able to see it. Any other questions or comments? Okay, thank you very much. So Kevin, with you, let's talk about the staff survey.
Yeah, so Tim touched on this actually earlier in his chief executive's update. So the areas that we're focusing on are some of those areas where we know we're behind. There's an appendix in the reading room that I'd also encourage you to try and read if you can. And what we've tried to do with this paper is to highlight not only the data and the figures and where we stand, but also the actions that we're taking and where we've already got actions, where we need to add to the actions that we've been taking, and some of the timelines on that. And people would have seen at the board seminar and the people committee review it regularly, our people priorities, and what we've done in the paper is mapped the people priorities to the staff survey areas and the questions that they relate to, so that we've really built on what we're already doing and it being embedded in our core governance, through the EMB people group to EMB to people committee to the board, rather than having a separate staff survey plan that's outside of any of that. So again, I probably won't say much more than that, and just open it up for questions really.
Thank you. I want to Sim, I know you've thank you for your hand up, but yeah, I know you've gone quite deep on this on the people committee, and I wondered if you'd like to expand a bit on that as well as any questions you've got.
Yes, obviously this is a very important annual survey that comes out. So to familiarise myself, even before the committee, I went through with Kevin's team, who took me through page by page to understand the data and just have a look at that. Then it went to the people committee where we had extensive conversations. And what came up there was the fact that, whilst we had the same sort of engagement as last year, it's still not full engagement from the rest of the trust. So we've got a limited view. So there's an acceptance that is that, but that we're not complacent. It's up to then the trust to seek other ways and to find innovative ways to engage staff that wouldn't usually feel safe to talk about what has happened or to give feedback. So there's a constant, I think the trust is constantly looking for ways to do this, and I just want to report that that comes through even when non-exec colleagues go to wards. We pick up and are able to triangulate some of what we're hearing through our sort of feedback from the ward visits. We've got freedom to speak up guardians where people can go. And the most important thing probably are the pulse surveys that this trust does to regularly pick up on information. And listening at the moment is one of the key objectives for most institutions in this country, be they private or public. Listening to staff and really hearing and then engaging and putting in activity which focuses on improving their staff experience is vital at the moment. So we can't let the baton go. And really it's just focusing on that and assuring the board that we're constantly looking at it.
Sorry, Matthew, I forgot to say actually that one of the things that we're going to focus on is really getting the response rate up. As you all know from London Northwest, they got 61% response rate, which is much better than we managed to achieve. And one of the things we're really focusing on is getting the response rate up.
Thank you, Kevin. Any other questions or comments? Thank you. So I think the point I would take away from this is that this is not a bad report. It's a sort of in the pack in terms of what the staff are saying about us. If I think back to the way Julian talks about our in-hospital mortality rate and the fact that we're now doing an investigation because we've dropped out of the top 5 in the country, it would be nice to think that we could bring the same level of rigor about our staff satisfaction and joy at working for the organisation as we bring pride to the quality of the care that we deliver. And I suspect that investing in what staff think of us and what they think of working here is the paying forwards against what our quality is going to look like in 5 years' time. So I think let us not be comfortable with being in the pack. Let's work out what we need to do to be outstanding. Tim,
sorry,
I knew that would provoke you.
So I mean, just to give an absolute assurance that we are absolutely not content with where we are, but I think it is important, I guess, and I think the Shelfer Group summary is a good one. If you look back, back to 2018, we were 7th. We're now joint 3rd in terms of the Shelfer Group engagement score. So I think there is continued focus on this, but I think it comes back to all of the work we're doing around culture, and making this a fair place to work, and as you pointed out earlier, really visibly doing that, I think is incredibly important. And I do think upskilling everybody to manage in the way that we need them to. I mean, if we can get the improvement through people management program genuinely functioning, I think that will be a huge step forward. It could be transformational for the organisation, because I think it's those relationships, I think, that drive some of the issues that we have. And I think, as Sue Grange would say if she were here, people join an organisation and leave a manager, and we do need to absolutely crack that, and we know that we're not there yet.
Great, thank you, Peter.
Yeah, thanks. Just a quick one, Tim, on the last thing that you said, which I wholly endorse. Are you talking there principally about first-line supervisors, i.e. people who affect the day-to-day lives of, in the greatest way, of the people who work here?
Yes. So basically, the improvement through people management is a program that I want to deliver a set of skills and expectations from the very first moment that you are responsible for another human being in the organisation. And I think it's equipping people with some key skills. And Kevin Croft will have heard me say this before. It's around things like, how do you manage people that you don't naturally get on with? How do you know when you're, and this is a very popular word, but how do you know when you're being triggered, and how do you then take a step back and deal with that situation? Because so much of what I see comes onto my desk is stuff that really should have been sorted out at the first or second meeting where there was an issue, and you've, instead of de-escalating it, we've somehow managed to escalate it, and then it escalates itself all the way up to the chief executive. So I think it's the real basics of day-to-day managing the group of people that you work with.
Thank you. Any other comments? Thank you. Excellent. Moving on to the People Committee board summary. Sim, is there anything you want to draw out of what we have in front of us?
No, you can see the continued focus on the areas, a lot of the areas we've discussed today, but also to remind this board that we also look at the health and safety of the trust. So there's a good framework now in place, sort of instigated by the audit committee. So that health and safety sort of universe has been set up. So we take this item through the People Committee, and then if there are any areas of quality, that's then passed on to the Quality Committee, and it comes back through audit. So just to assure the board that's covered as well as the other people issues that we've talked extensively about today.
Thank you very much. Okay, I shall move on to governance and the annual provider licence compliance. Peter.
Thanks, Matthew. So, as the paper says, all trusts are required to publish an annual self-certification of compliance with some specific conditions, and the background to this was around foundation trust compliance conditions, but this has been extended to all NHS trusts. So you'll see in Appendix 1 the summary of our compliance statements against each of those provider conditions. And I think the important thing to say is, whilst we recognise there are risks to the delivery of those standards that are included in there, we feel that we have got robust enough governance processes to keep us on track and manage those risks. This has been reviewed by Audit, Risk and Governance Committee, have scrutinised the statements, and I think they're happy to propose these to board for approval.
Great. Any questions? Everyone happy for us to approve this? Indicate your assent or dissent. Yes, thank you. Thank you very much. Okay, that is approved. Moving on to the Audit, Risk and Governance Committee board report. Kay, is there anything that you want to pull out for us?
No, it's the usual for this time of year. We're sort of in the middle of closing off the previous year with the audit and starting the new year. We also saw the changeover of internal audit providers. So it was very much a transitional meeting, I think it's fair to say.
Thank you very much. Any questions or comments? In case, we will note that report. And moving on to Board and Committee Effectiveness Report. Peter, back to you.
Thank you. So this paper summarises the outcome of our annual effectiveness reviews, which have gone through all the respective committees. So each committee has seen their own individual results. This is a combined version of that, which has also been shared with Audit, Risk and Governance Committee. The key point of this for Trust Board, I think, is to seek approval of the terms of reference for each of our committees for the next year. They're included in the reading room if people want to reference them, but again, they've been approved by each board committee before coming here.
Any questions? Very good. So firstly, we will note the report, and are people happy to approve the terms of reference? I'm seeing nods around the room. Thank you very much. They are approved. And then moving on to the Redevelopment Committee report. Bob, anything you want to share with us?
Thank you. I hope it's pretty self-explanatory. I would emphasise something that isn't emphasised particularly in the report, which is the work that is ongoing to quantifiably baseline our green plan proposition. And a lot of work on the decarbonisation metrics has taken place, but it's not completed fully. And I have asked that at some point in the autumn, we bring back an update to the full board on the green plan with numbers in it. And I can see Bob desperate to come in to reaffirm that. So I shall give way.
Bob.
Thanks very much, Bob. Really just to say, Matthew, that there's a huge amount of work gone in on that. We'll aim to be, it'll realistically, I think, be sort of November time, come and bring that latest piece of work that will talk about the initiatives of the work, some of the really big things like the decarbonisation work, but also many people-led things that our amazing staff and patients and local communities are driving forward on it. With that sense of measure, we've got a much better set of data that shows us where our baseline is. I think we'll be able to have an extended version of that and also be starting to show where some of the areas of progress are. So that's one for about 5-6 months time. Great, thank you very much. Mr. Alexander, anything else you wanted to say?
No, thank you.
No. Any questions or comments? We're happy to receive that report. Okay, that is good. So I've now got to any other business. I've not been notified by any other businesses other than to say that Jazz won't be with us for the next one of our board meetings. So her deputy Desiree Brown will be standing in for her. Have I got any other AOBs that have come through?
I'm aware of, no.
Anybody wants to raise? In which case, I shall take this opportunity to invite members of the public to raise any questions with us. And Abdi Fattah, please share your question. You could come off mute, sir, and you can ask your question.
Yeah, sorry, sorry about that. Thank you very much for giving me the time to ask a question. I have a range of questions, but I'll start with adding my ideas on the discharge management. I think I echo the suggestions by Kay, which is very good. But also I see that there are other problems. I think it is not the downstream, the admission, and there's mismatch between admission and discharge from the point of view of the downstream. But also there's upstream, which I think the accident and emergency. There's also mismatch there. But I think the problem is not so much of the flow of the patients, but also but the culture and strategy. So I don't know how Khaled would be able to do it, but I want to ask a question to Khaled. As your success in the organization, like everyone else in your caliber, depends on heavily on spending more time outside than internally. And as the first, you need to gather feedbacks and information to help your team predict the problems that need to be solved ahead of the curve. When you are going through bandwidth taxing and not having a slack time, how do you gather external feedback to predict the problems ahead of the gap, ahead of the curve, and help your team to solve them?
So I think that's a question about how do we see problems coming over the hill towards us. I don't know whether, Tim, do you want to have a back of that or hand it off to someone?
Yeah, I mean, I think it's a good point. I think the danger, particularly at this point in time, is that we all sit here and just focus on what we need to do today, tomorrow, and the day after. And of course, there is a big agenda here. And as you know, there are 6 million people in the NHS who are waiting for treatment. And so we do need to really look ahead. And I think at the moment, the key things for us are really to make sure that we are getting back to recording the data that we have internally as effectively as we can, and that we are investigating early any little warning sign. So you'll have seen that we've moved to really looking at SPC charts so that we can get a better idea of when things are moving out of what you would regard as the normal statistical range, so that we can grab them early and have a look. I think that, as we've described in a range of areas, for example, with the standardised mortality, Julian and the medical director's office have identified there doesn't appear to be a significant problem, but we need to get into that and understand, is there an issue there that we need to look at? But I think you're also right, on a sort of bigger scale, we need to make sure that we are comparing ourselves externally. So one of the things that we do here is we look across the other members of the Shelford Group, which are the big teaching hospitals across the country, so that we can then get an idea about how we're performing and where there may be areas that we need to look at. And the medical director, the nurse director, the finance directors and the chief operating officers all have their own groups to do the appropriate set of benchmarking. We've then obviously, one of the advantages of the collaborative is we can do that benchmarking across Northwest London so that we can see across basically the same population where there are differences. And then there's a lot of stuff now going on at a national level that I engage with, that the medical director, nurse director and the chief operating officer particularly engage with to get intelligence from what's going on across the rest of the country. So we know where there are problems at the moment and we can come back and check, are we likely to have the same sorts of problems? So it's a sort of, as with everything in life, it's triangulating all those different sources of data and trying to predict it. But the key thing, I think, you sort of slightly alluded to, is to make sure that we lift our heads up frequently enough from the day-to-day to make sure that we are getting that level of strategic overview.
Thank you for that, Tim. Anyone else?
Yeah, I have other questions. Huh?
Please.
Yeah. I wanted Khaled to answer, but yeah, no, never mind. Yeah, from the point of view of the culture, I think there's a mismatch between attitude and the culture. Also, there's a mismatch between imagination and the environment. How would you balance these two, Tim?
So I think that one of the issues that I have, and I particularly need to focus on, and we do spend quite a lot of time focusing on, is the organisation is very big and it's spread across a number of different sites. And as you know, because you come frequently to these meetings, you know, we have spent a lot of time really trying to make a step change in the culture across the organisation. And as you will recall from years gone by, you know, I think the culture in the organisation was absolutely not where it needs to be. But of course, and we've had this discussion at the beginning of the conversation this morning with Raki from the therapies, where actually getting stuff down to the front line in an organisation of 14,500 people is a constant challenge. And it's one of the things that I'm particularly concerned about, is that there's no good me and other people here espousing the values and culture of the organisation if that actually doesn't feed down into the day-to-day culture of the organisation. And I think, honestly, we haven't got that completely right yet, but we need, it's why we set up a number of these programs that we're doing, so the people management program and others, to try and really make sure that we do get that embedded. Matthew's just mentioned induction. That's a really important way of setting out, if you like, the contract between the individual who comes to work for us and us as an organisation about how we do stuff. So, you know, do I think we've got it absolutely right? No, I absolutely don't. Are we committed to trying to make it better? Yes, we absolutely are.
Can I see if there are,
yeah.
Okay, well, let me just take a question from someone else.
Yeah.
Nick from the HSJ, we are honoured to have you with us. Please. You're on mute. That's the easiest question we've had from the HSJ for a while. Nick, did you have a question you wanted to ask it? Do you want to come off mute to ask it?
I have two questions, if you can give me a chance.
Wait, hang on. Nick, did you have a question? I'm going to assume
we have enabled the chat function. So for Nick, if you can't speak for whatever reason, you can always put it in the chat, and we'll try to pick it up that way.
Okay, I will take one more question from Abdi Fattah, and then I'm going to wind us up as last question.
Yeah, thank you very much. Yeah, I want to ask as well the cancer diagnostic matters. I have discovered that you send some patients to private centers for diagnostic matters and also for treatment, post-code or otherwise. Can you compile the list of the people who were offered for private treatment for transparency and trust-building reasons? Second, in line with this, is this option viable and financially sustainable in the longer run?
I think that's probably one for Katie Urch, if she's.
This is use of the private. This is a question about the NHS using the private sector as additional capacity for diagnostic or elective treatments
for cancer.
For cancer. So, Katie, do you want to say something about that? You still with us? Oops, I think we may have lost Katie. Tim, do you want to say something about the general principle of the NHS using the private sector?
Yeah, so I think at the moment, we don't send a large number of people with cancer for treatment externally to the trust. So certainly in terms of treatment, we do the treatments ourselves, and indeed we take patients in from the rest of Northwest London for some of the more complex cancer treatments. So in terms of the treatment, that is almost exclusively done in terms of internally and in our own operating theatres. I do think that it is reasonable to use the private sector if you have a significant capacity problem, and as you will be aware, there is an arrangement with the NHS generally that we can use the private sector if we need to, but I think the aim would be ultimately to get to a point where we can deliver this from NHS resources, and I think it is financially viable in the short term because we don't need to do it for a very large number of people, and also we would negotiate a very minor uplift on the NHS tariff so that we wouldn't end up, wasting NHS money on these on private sector unless it was absolutely essential. We have on occasion used some private facilities for some cancer diagnostics, particularly during COVID. And whilst we have been refurbishing one of our own endoscopy rooms, so endoscopy obviously is used for the diagnosis of upper and lower GI cancer, and we have taken some space in a private facility for a period of time, and that was done at the same sort of cost that it would cost the NHS. So again, it was not a significant cost pressure, and it allowed us to keep up with the normal levels of treatment that we would provide whilst we were refurbishing some of our own endoscopy suites.
Great, thank you. So I'm going to stop you there. I'm going to let Nick come in with his question if he's managed to unmute himself now. Okay.
Is that better? Can you hear me?
Yeah, we can hear you. Thanks.
All right. Sorry about that. My question is more related to this kind of holistic approach in Northwest London as to how Imperial will manage, meeting its selective targets to recover from the pandemic, while also kind of feeding into helping the region as a whole get to that target as well. So obviously Imperial being quite a large trust and obviously having quite a lot of resources to try and meet this challenge, is also trying to make sure that Northwest London as a whole meets that. So what specifically will Imperial be doing to help the other providers if and when they need it, while also meeting their own challenges?
So, I mean, it's a good question, Nick. So I suppose the first thing to say is, one of the conversations we've had as a board is that, if you look at the acute collaborative, then, the turnover of Imperial is approaching half of the turnover of the collaborative. So it is really important. The first thing to do is it's really important that we meet our own internal operational plans, and I think that we are reasonably confident that we can do that. We have already seen a shift of some, which has happened during the pandemic, of some more complex work into Imperial from other parts of the sector, and again, particularly actually around some of the more complex cancer work. And I think that that will alleviate some of the issues in some of our surrounding partners. We've actually got a system where over the course of the last, I think it's year and a half, we've had 3,500 people who've moved around our Northwest London sector in order to take advantage of capacity across the sector. So we have a good mechanism of doing that. We have a regular prioritisation meeting which the medical directors have every Thursday to make sure that across the sector all of our P2 surgery is being done, and if it's not being done, that we utilise resource across the sector to do that. And we've certainly taken people in, and because obviously we have a decent sized intensive care unit, we have taken intensive care patients from across the sector. So it's an ongoing issue. We get an overview of that through the acute care board at an ICS level, and as Matthew referred to earlier, we've now got a series of work streams led by the different chief executives, which will, I think, help us to sort of turbocharge some of these things around quality and operational excellence.
Thank you, Tim. And I think with that, I think I'm going to wrap up the meeting. Just Abdi Fattah, I know you have a whole host of other questions. If you would like to email them into us, we would be happy to deal with them. But I think probably a one-to-one between you and the chief executive with an audience is probably not the best thing to be doing here. So thank you all for joining us from the general public who've given up their time. Thank you to the non-executives, and thank you to the boards for the meeting. And I will close the meeting here. Thank you very much.